Okay, so welcome back everybody. This is the second video in the series. For those of you who may not have seen the last video, my name's Steph, I'm the dermatologist at Langford, and this is a series talking about otitis. And in this video we're going to be talking a bit more about a really systematic approach to diagnosis. So history taking. This is something we're all really good at and we do every day in practice. But sometimes with otitis I think we lose sight of some of the key questions we should be asking. We get really zoned in on, well, this dog is having recurrent ear problems. We narrow down on questions we might ask, you know, has the dog been scratching? Has the owner put something in the ear? But we don't necessarily look at the wider picture, and I think that's where sometimes it can go wrong. So, key things to think about. First of all, is the dog well? And in most cases, yes. Like we said in the previous video, most of these cases are allergic dogs. They're going to be young dogs. They're often not systemically unwell, but we don't want to miss some of our other differentials. We mentioned pemphigus briefly, there are lots of others, where the dog might be unwell. So has there been any change to toileting, appetite, thirst, any vomiting or diarrhoea? And indeed this might give us other clues. If this is a dog that gets a recurrent ear infections, but also gets upset tummies, might this dog have a food allergy? So this is really important. And then ear and skin specific questions. So when did the owners first notice the ear becoming a problem? On this occasion, they may have only noticed it in the preceding days, but actually has this dog been having ear problems since it was 6 months old, 2 years old? How long has this been happening for? What symptoms are they seeing? Are they seeing head shaking, ear scratching? Does the dog circle? Does the dog hold the ear on one side? All of this is going to give you a clue as to what might be going on. A really important one is, are the owners putting anything into the ear at home? Many owners know, but we do have owners that are cleaning ears at home using wipes. Thornets powder is going out of fashion now, but we still do have owners putting powders into the dog's ears at home. And as I mentioned in the last video, I've had owners putting quite weird and wonderful things into ears. Apple cider vinegar seems to crop up more than you think, and even I've had dilute Dettol previously. So we just want to make sure, is the owner putting anything in? The other thing they sometimes use is they may have had a bottle of, for example, Sualan from previously, and they've started reapplying it. So really important to check these things. As I've already mentioned, does this dog have a history of ear problems? Is this, hand on heart, the first time this has ever happened, or has this dog been having ear infections regularly? If so, what was the response to previous treatment? What was used? What worked well? What worked less well? And what do the owners see in between? Is this a dog who is completely perfect for 6 months and then has a flare-up that responds within a week of treatment? Or is this a dog where the ears are static and have been grumbling for 6 months, and perhaps the dog was a little bit more comfortable with treatment, didn't get perfect, and then is worse again? So these are all things we must ask. And then some things that may seem less obvious: travel history. It's unlikely that a dog with only otitis is going to have something like leishmania, for example, but we're seeing a lot more imported dogs or dogs that travel. So particularly if there are any other skin lesions, we do want to make sure we're thinking about travel history. Are they up to date with parasite treatment? As we've said, it's unlikely we're going to have otodectes in an adult dog, but we do sometimes see our more generalised Demodex, so again it's useful to know what parasite treatment they're using. And then finally, has there been any other skin involvement? And I find this requires a bit of a two-prong approach. We're all taught we start with our open questions, so I would typically say to owners, have you had any problems with the rest of the skin, for example? Has there been any other skin involvement? Many owners will say no, and that might be true. If they say yes, then I might dig a little more into that. But even if they say no, I may ask specific questions such as, do they nibble their feet? Do they scratch? It's amazing to me the number of owners who will say, no other skin problems. And then when you say, oh, okay, do they chew their feet? They say, oh, yes, they do actually. And so I think we do need to start with our open questions and then just narrow down a little bit and ask our specific questions to help us identify, actually, does this dog have any other problems with its skin? Okay, and then on to our clinical exam. Again, this is something you guys are doing every day, multiple times a day, but I just want to draw your attention to a couple of points. What we mustn't do, similarly with history, is focus only on the ears. So with every case we see of otitis, we should be doing a full clinical exam, because we may pick up things we're not expecting. These may not be related to the otitis, but we don't want to miss them if the dog also has a heart murmur, for example, that might affect our treatment choices. And then we need to do a full dermatological exam, not just the ears. We should be checking the lips, the chin. Is there any facial involvement? Does this dog have lip dermatitis, for example, or chin acne? We should be looking at the feet, the foot pads, the nails. Is there any redness, inflammation, discharge? Are they wet? Are they saliva stained? There are many dogs that come in with very, very brown saliva stained feet that the owner swear blind the dog never licks. And in this scenario, I would question, is this dog doing sneaky licking? Are you out during the day? Is the dog going to a different room, or are they doing it at night? Because that would really prompt you to look more at, actually, I think this dog is licking their feet, and in combination with otitis, this is all putting us more in the realms of an allergic picture. What are the armpits doing? What's the tummy doing? What's the coat texture and quality? Does this dog have a dull coat, a bit scurfy, a bit greasy? Do they have a yeasty smell? Is there any hair loss? Often not, but we may see, for example, patchy hair loss on the legs if the dog has been nibbling. And do you get a positive itch scratch response? Now this is really easy to do in practice. Really all you're doing is making a fuss of the dog, but you're doing it in a sort of relatively stimulating way. So you might be kind of scratching on the back or rubbing the belly or just running your hands up and down their sides. And what you're looking for is, does the dog scratch? Some dogs will have a kind of really subtle response and they might do a little shiver or kind of lick their lips or just lift a foot. Some dogs will really obviously start scratching the minute you touch them. And then there are other dogs where, and I find these are perhaps the dogs where there's a bit more adrenaline involved, perhaps a really stressed spaniel. They won't scratch on cue, so when you try to stimulate them to scratch, they won't, but they will then scratch repeatedly throughout the consult. So how itchy is this dog is really important, and where is the itch? Is it just the ear that they're bothering, or is it everywhere? Okay, so now we're going to talk about examining the ears themselves, and there's quite a lot of information we can get before we even pick up the otoscope. So first, we're going to have a look at the pinna themselves, and we're looking for any hair loss, any red sore areas, any crusting. Has the dog been scratching behind the ear and made a sore area? Has the dog split the tip of the pinna where they've been shaking their head? And then we're going to have a feel of the external ear canals, and what we're looking for here is, do they feel soft and pliable, like a normal healthy ear canal? Or are they starting to become rigid, perhaps with a more corrugated feel? Are they painful? These are reflective of more chronic changes. I would usually work my way up from the bottom, so bringing the hands up, we're going to be gently doing kind of scratching, touching around the sort of the chest and the neck, which is non-threatening to the dog, and we're going to gently work our way up. We're not going to suddenly grab for the ears rapidly. Many of these dogs can be very sensitised to their ears being handled, so it's really important to go slowly and gently. I would recommend then trying to have a look at the opening to the canal. We may not need to flap the pinna back in a breed such as a French Bulldog, but if we've got a Labrador or a Spaniel, for example, or a Cockapoo or a Labradoodle with big ears, again, I would use the hands. Again, we've worked our way up, and we're just going to gently flap those pinna back. Most dogs will let us do this, and it gives us an indication, again, of how the dog feels about the ears being handled. We can then look to see, is there any redness, any inflammation, any discharge, any crusting around the entrance to the canal? Does the canal look open, or actually is it very stenotic and closed up? There is a joke about dermatologists loving to sniff ears, and knowing if there's any odour is important, but I would always advise caution. We don't want to be putting our faces very close to a dog that may have an aversive reaction to that. So if you are able to have a little sniff and see if there is any odour, I would encourage you to do so, but obviously exercise caution and make sure you're not putting yourself in a dangerous position by doing that. And then I would recommend we do cytology before we pick up our otoscope. If we try to look down the dog's ear with the otoscope first, the dog panics or is very painful, and we then can't get our cytology sample, that's much less helpful. I would encourage you to get cytology first and then come to the otoscope at the end. And there are a couple of ways that we can get a cytology sample. The traditional is obviously with a cotton bud, but many dogs can be very panicked by the sight of a cotton bud, either because they've had a history of ear problems and they know what's going to happen, or they think it's going to hurt, or they're just very worried about the whole thing, or perhaps both. So a gloved finger can really help in this scenario. Similarly to the examining at the beginning, I would be just working my hands up very gently, keeping a finger clean, and you're just going to work it into the ear canal. Now, most dogs will tolerate this. They may worry a little bit as you start to enter the ear, but if you go very gently and slowly, perhaps a hand on the opposite side of the face to gently reassure and steady the head. And most dogs will then lean into what it is effectively an ear massage with a gloved finger, and you can get a nice cytology sample that way. You can then press it gently onto the slide and you've got your cytology sample. If you are using a cotton bud successfully, we can roll that onto the slide, and we'll look at what we do with our cytology samples a little later. And then finally, our otoscopic exam. Now, we do want to look at every ear if we're able to, but in many cases it's simply not possible. And I think it's important to remember that we do want to be able to see these dogs again. I've had numerous reports of dogs being pinned to the ground. One dog was even tied to a table, and I've had dogs shut behind kennel doors before, all reported from owners. I think this is not helpful from a long-term point of view, because that dog may be very reluctant to come back for example, a booster. And if this dog is then having ongoing problems with its ears and has had a really negative experience, of course they're going to be much more averse to handling and treatment in future. So I would urge you to be gentle, slow. If this ear is very painful or the dog is very panicked, don't try to force the issue with the otoscope. Do we perhaps need to give some anti-inflammatory and pain relief therapy first and then review the dog in a week's time, a few days' time? Do we need to think about having the dog back for a general anaesthetic and an ear flush, or even just to sedate to have a look down the ear? Do we need to consider giving anxiolytics, for example some gabapentin or some trazodone if appropriate, to look at the ear with another visit? It's important to think about these things and not become tunnel-minded with the otoscope, because we can quite easily create a very large aversion and quite a long-term problem. So we've already spoken about the approach, but what are we looking for with the otoscope? Well, a nice normal canal is going to be pink, smooth, healthy looking. We may see a low volume of cerumen, that's okay. We may be able to see the eardrum. Now, this isn't always possible in a conscious animal, just because they can be wriggly or not keen on what we're doing. And we have to really straighten the canal to see down the vertical and horizontal canals. If this is a sore ear, this just may not be possible, but it's always good practice to see if we can see the eardrum, because that's going to give us very useful information for treatment. We're looking to see if there's any inflammation or redness. Is there any glandular hyperplasia? So are we seeing a cobblestone appearance to the ear? Is the ear canal stenotic? Can we see a grass seed? All really useful information. And then we've already touched on cytology and how we're going to get our sample. We should be doing cytology in every ear we see, every time we see that ear, unless there's a reason not to. For example, if the owner declines for cost reasons. We've talked about the swab or the gloved finger. We're going to stain with Diff Quick. So we will use our fixative, our red stain and our blue stain. But in fact, with a ceruminous sample, you don't necessarily need to use fixative. And in fact, there was a study looking at just using a few drops of the blue stain. So there are a variety of ways of preparing these slides. And if you are time constrained in a consult, there are ways of doing it slightly more quickly. Equally, is there a nurse in the practice that's good at cytology who would be happy to help look at the slides while you're chatting to the client? I think it's also appropriate to say to the client, this is really important that we look at this slide, but I don't have time right now. This is particularly true in a 15-minute consultation. But is it okay if I look at the slide and I ring you later with a plan? The majority of owners are going to be happy with that. And I would urge you to make sure you do look at your cytology, because it's so important for guiding treatment decisions. And of course, we're going to start on low power and then build up to our high power and our oil lens. Okay, so let's just have a quick look at some common cytology we're going to see. Here we have malassezia, our old yeast friend. Now, we will see a low volume of malassezia in normal ears and skin. Both of these pictures have a slightly higher than normal amount. Well, what is higher than normal? We don't have an exact answer for that. An often cited figure is more than 5 to 6 per high-powered field is considered excessive. But it's important that we take into account the whole picture. So if we were to look at an ear that was beautiful, pink, clean, no redness, no inflammation, perhaps a tiny amount of normal cerumen, no odour, with a dog that was very comfortable, and we saw 4 or 5 malassezia in a high-powered field, I might not be too worried about that. However, if I saw that same amount of malassezia, perhaps with a couple of neutrophils, and the ear was red, inflamed, the dog was scratching, that would be much more of a worry. So I think we do need to take into account the whole picture when we're looking at the amount, but here are some examples of increased malassezia numbers. And then some cocci. Now you'll spot there's some malassezia there as well. It can be quite tricky to find a slide, in fact, with just cocci, because it's very common to see malassezia as well. And again, this is an increased number of cocci. We see our Staphylococcus most often. This can increase with inflammation, and so you will see a low amount in a normal ear. Similarly to malassezia, if there's a larger volume or we're getting some inflammatory cells, this is more abnormal, and here's an example of just that. And then rods, what we all hate to see. Most commonly this is going to be Pseudomonas, but we do see other rods as well, sometimes Proteus and E. coli. We can see some degenerate neutrophils there. This is a large volume of rods. Rods are always abnormal in the ear though, so even if we're seeing 1 or 2, that does want treatment. So yeah, useful to look out for rods. And some inflammatory cells. As I've already mentioned, these are abnormal. So if we ever see inflammatory cells in the ear, that's an unhappy ear. We can see there is a low volume of rods there as well. Okay, so I just want to talk about culture and sensitivity now. This can be a little confusing, I think, because we use culture quite a lot in other ways, but it's of really limited use in the ear. This is because our culture and sensitivity results are based on in vitro or systemic testing. And we can exceed the MIC by many thousands of times when we're using a topical medication. So if the lab reports that a bacteria is resistant to a certain antibiotic, that means we can't give that antibiotic orally, but it doesn't mean that the antibiotic won't be effective topically. So for this reason, culture is not very helpful. Cytology is our most useful tool for assessing these ears. Now, when might we do culture? If we see rods and we want to know what type of rods we're dealing with, then we can culture. If a client had some cost constraints, this might not be helpful because it's not ultimately going to change how we treat that bacteria. We're going to treat empirically. The other time it's useful to culture is at the end of treatment. So if we've been treating a pesky Pseudomonas infection, for example, and we get to the end of treatment, the cytology is clear, I would encourage you to take a culture before you stop the treatment, because we've had cases where actually there has still been a little Pseudomonas floating around, and it's useful to just extend treatment by another, perhaps a few weeks, just until we get resolution. But other than that, and if we're going to be treating with oral medication for otitis media. Otherwise, cytology is our big friend. And then I just want to touch on advanced imaging. I've just mentioned otitis media. If we have a very chronic case, it's always useful to just think, could there be middle ear involvement here? The most common cause of otitis media is extension from otitis externa. And the eardrum being intact doesn't necessarily guarantee there is no otitis media. Equally, do we have a space occupying or a structural lesion? We'll sometimes see fluid in the middle ear, polyps in the middle ear. We can see paraoral abscesses where the bulla has actually lysed and there is an abscess, which is an indication for surgery. And sometimes we just see extremely end-stage changes which are not amenable to medical management. And so it's important to just think about that. If we've got a really chronic case which perhaps isn't responding well to therapy, does this dog actually need some imaging? We can MRI these cases as well, but typically when we're wanting to look at the bulla, we would CT. You can X-ray, but it's not considered very sensitive. So personally, I would recommend CT in these cases. Okay, thank you for listening to this video, everybody. In the next one, we're going to be looking at the approach to treatment for otitis. So please join us for the next video.